Welcome to Global Diabetes Insights, your go-to podcast for navigating the world of diabetes. I am Tino, a certified diabetes educator and a global advocate for non-communicable diseases.
And I'm Kona, a global advocate and a medical doctor. Together, we're your hosts, dedicated to raising awareness, fostering open discussions, and creating a safe space for everyone affected by diabetes.
Join us as we dive into empowering conversations with individuals living with diabetes, caregivers, healthcare professionals, and researchers. Our goal is to not only guide you through effective diabetes management, but also to inspire advocacy for proper healthcare access.
So get ready for a journey of insights, ideas, and diverse perspectives. Let's amplify our collective voice and create positive change. Get involved, get engaged, and join us in creating the change we need. So welcome everybody to Global Diabetes Insights.
Welcome to the Global Diabetes Insights, and we are here in the heart. I don't know if it's the heart of Italy because it's not the capital, it's Florence, right? But I mean, I'm not an Italian myself. I could have used some Italian language, but anyways, it is what it is. So today we have with us Dr. Brynn, but of course I usually call her Brynn, but today, before the podcast, I will call her Dr. Brynn Marks. We are going to ask her questions about diabetes and everything that she's doing, the research work, everything that she does in the diabetes spectrum, trying to change and ease the things that we need, improving the care of people living with diabetes from all over the world, not just in Philadelphia where she lives, because she works with ISPA, right? So Dr. Brynn, I think maybe if you could introduce yourself to the audience, that would be perfect.
Sure, thanks for the intro, Tino. So my name is Brynn Marks. I am a pediatric endocrinologist. I work at the Children's Hospital of Philadelphia in the United States, but I also live with type 1 diabetes. I've had it for over 30 years now. I was diagnosed when I was 5 and sort of been through the phases of struggling with diabetes management, and eventually realized that after I overcame my challenges, I wanted to go into diabetes as a healthcare professional. So I spend most of my time now doing research, really interested in how we teach people how to use the technologies, the continuous glucose monitors, the insulin pumps, and the automated insulin delivery systems, and trying to use apps to teach people how to do a little bit more with problem solving. But I've also done some work trying to get technology into the hands of those who have historically not had access. So I'm really just interested in getting people access to the technology and being able to use it well.
Well, thank you so much for talking about this. Already you've shared on your connection with diabetes that you have, because you also live with diabetes, not just your profession, you working in the diabetes spectrum, you also living with diabetes yourself. So maybe before we talk about the work you do, tell us more like the status quo of health or the status quo of diabetes care in your own state, Philadelphia.
Absolutely. So in the US, we are pretty lucky because most kids have healthcare insurance. As long as they are US citizens, there's a mechanism for them to get access to insurance. And with that, even the public healthcare insurances that people have when they can't afford the private insurances, they do cover the technologies. They cover visits, they cover insulins, they cover test strips. So it's not a lack of resources, it's not a lack of access, but it's making sure that we're actually getting it to people and that they're using it well. Because despite these opportunities, we have the same inequities that are seen in other parts of the world.
Thank you. Oh, that is amazing. Okay, Brynn, I need to know, like, of course, you were diagnosed as a kid, like, for example, yes. From your experience, knowing the challenges that children go through and the families, because once a child is diagnosed, it also affects the family, everybody in it, in the picture. What are sort of like the challenges family has to go through when a child is diagnosed, and how are you assisting them? I know that you are mostly working in the technology issues, but then I need to know like how you are helping people to improve their care, especially for those with newly diagnosed in their families.
Yeah, thanks, Tina. It's such a great point because you can't get to the technology until you have a good foundation. So that's so important. And for me, being diagnosed at 5, I was really lucky. I have a mother who's a physician. My dad works in biopharmaceuticals, so a lot of knowledge in the family. And yet I was the first person in my family to be diagnosed with type 1. I think at 5, it was in a way nice for me because I don't remember life without diabetes. You know, all I can think about is carb counting and giving insulin. And for me, this was back before technology. I was pricking my finger. I was using the NPH insulin where it was twice a day shots and I had to eat the same amount of carbs at all times. So I lived through that. And I guess it was just was what it was, you know. I didn't know any better, and yes, it got frustrating at times, and I remember sort of battling with my parents when there were special occasions or things that I wanted to eat that I couldn't eat, or trying to make it work with sports. I have 2 younger brothers who are both healthy. Neither one of them has diabetes, and as I got older and started to see the differences, I think that was hard, seeing that I wasn't exactly like everyone else, that I had to do extra things. And as I became a teenager, that's really when I got into the problems, because I just didn't do it. I was at an age where my parents couldn't force me to do things. I would say I did things, but I wasn't doing them. So there were a lot of battles, and for a long time I just sort of scraped by with terrible blood sugars, just enough insulin not to go into DKA. And I guess growing up over time, you know, I don't know exactly what it was. I wish I could give you a single switch that was my light bulb moment that made me think differently, but I think it was just kind of growing up and having the support of an endocrinologist, giving myself a little bit of time to mature, letting that brain grow, and gradually started taking better care of myself. And what I noticed and what kept me going was that my blood sugars were better, I felt better. And I think that's something that we don't talk about enough. So really interested in spreading the word about that and helping, I think, kids and families to understand, because some of the high risk work that I've done, taking kids with A1Cs that are unmeasurably high and then getting them into the 8s and 9s, parents are telling me they have a new kid. So just helping people to see that and helping them to live the best lives they can with diabetes.
Wow, that is beautiful. Thank you so much for putting it that way. So now, knowing that you yourself, I would say you're privileged, growing up in a family where people knew so much about diabetes because of their work. So like, can we say that how you grew up, was it like something that made you just to specialize on helping the kids living with diabetes, or it was something that just came naturally? What can you tell us about that? Where did that come from?
My mom's a pediatrician. I think that played a huge role. I knew I wanted to be a pediatrician, but for a long time I was going to do anything in pediatrics except for diabetes. For a long time I thought I wanted to be a neurologist. I studied psychology as an undergrad, and I was really fascinated in how the brain works. But ultimately realized that neurology is a lot of seizures, which was something I wasn't interested in. And over time, as my blood sugars got better, as I realized that when I was on my endocrinology rotations, I could really connect with people and share my experiences and make it a little bit easier for them. That was what pulled me in. And to this day, that's still what I love. So when I have my clinics, when I get to work with kids and when I get to work with families, there's the intellectual part. You know, there's thinking about the insulin doses and making sure that you're giving them the right recommendations and doing the right screening. But for me, there's a huge psychosocial piece, and it's finding a way to connect with people, because that healthcare team is such a huge support, and making sure they get access to all the resources that we have to make, again, life as easy as it can be with diabetes.
Wow, thank you so much. Thank you so much, Dr. Brynn, for about this. Like, everything that you're talking about is mostly about the support that needs to be given to people living with diabetes and also their families. Now, maybe we want like you to transition. Just tell us like a bit about your role, how you work as a director for technology for the Diabetes Center where you work now, and what kind of support is it that you're giving? Are you, like, I think you said it like in the beginning, where you're saying you are teaching people to say how best to use the technologies that they should be using. So what can you tell us about that? What is the background story, and what are you hoping to accomplish with this?
Sure. So I am really lucky to work with a team. We have a diabetes technology team at the Children's Hospital of Philadelphia. I have an amazing diabetes educator and a nurse practitioner who work closely with me. And in the US, we have to think so hard about insurance and processes and reimbursement. So with all the new technologies that are coming out, our role is to think about the technologies, to think about who is best suited to use them, who's going to get the most benefit, so that we're counseling people when they choose them. We think about getting the insurance contracts in place. We think about making sure that all of our diabetes educators know how to use these systems and can teach our families. So that's a lot of the role, and we have just been so busy because there's so many new devices coming out. In the US, the Dexcom G7 is new. We have the Freestyle Libre 2 Plus for integration with the automated insulin delivery systems. We have a new automated insulin delivery system where you don't have to count carbs, the iLet. So it's really just been a blast working with this team and thinking about all the resources that we have and trying to think about how to get them into people's hands so that they're prepared to use them well.
Oh, thank you so much. This is incredible work. We need, like, of course we might have access to the technology that we need, but if people don't know how to use them, then it'll be nothing. Probably it will not serve us the way we wish it could, or the way that it was intended. So there is a need of a training. So thank you so much for that contribution. We need that, and thank you so much for the people that you're working with that are doing all this incredible work. It was needed. It's key. It's mandatory. So thank you so much for that. We are moving on to the next section about you working as a medical doctor, not just as a person living with diabetes. If it wasn't for your diagnosis, would you have led into a different career?
It's a good question, Tino. It's a hard one to answer when I think about it, because like I said earlier, I don't remember life before diabetes. So I think for me, every part of my conscious self, there's diabetes integrated into it. I will say my mom had a huge influence. She did pediatric allergy, and she loved her job, just to see how passionate she was about it and how she could connect with families. That was actually initially what pulled me in. I wanted to be able to help people facing challenges, to overcome them, and to live full lives. So that was what got me excited. But I can definitely tell you, I think having diabetes is why I now work with diabetes. I really thought I was going to be a clinician. When I started my training, I was dead set on that. I wanted to be able to make that one-on-one impact. And after I did that for a little bit, what I realized is it's amazing to help those people that you get to see, but you see 8, maybe 10 people a day. Whereas with research, I can do things that enroll more people, that'll have impacts that we can put out on a larger scale to really make an even bigger difference. And ISPAD and my research have both given me a great platform to do that.
Bravo. Right. So I know this issue. Thank you so much for this one. We cannot really separate diabetes from you because you were diagnosed at a very early stage where we are not even thinking of career at the stage, at that moment, because you're 5. So now I know this one. I thought maybe it was just an issue that we see here in the low to middle income countries, but I've also heard stories or issues about it even in the US. What can you tell us about the issue behind the misdiagnosis that we are still experiencing in this world, especially when it comes to diabetes? What could be the reason? You, with your research, with the things that you're working on, the things that you're doing, probably you have a better of an understanding that people might not know. What can you tell us about this?
Yeah, I think so much of it boils down to resources, Tino. What's the test that you can do? What are the tests that you think to do? How quickly can you get the results, and how quickly can you interpret them? I think more rare in the US that we see a misdiagnosis, just because we have results that'll come back within a few minutes. We are very, very lucky in that sense, but it does still happen. And when I think about the places where it happens, it tends to be lower resource settings. It's places where medical teams are having to overfunction, where they're filling the role of many different specialists, and how much can one team handle. So I think that's a struggle. And then I look at places like Africa, I look at places like rural Australia, and think about the resources that are there. Do they have the tests they need to do? Do the physicians and the medical team have the education that they need to order the right tests? So I think raising awareness about diabetes, I think being at these conferences and getting the right people to these conferences is so important.
Oh, thank you so much for that one. Especially with the point that you're raising, to say, do they have the training for them to do what they are supposed to be doing? So my question now is to say, in the medical field, we have so many people, we have the general practitioners, pediatrists, endocrinologists, and so many others, diabetologists, as some may call themselves. But do you think, can a general practitioner, just a general practitioner, give enough treatment to a person living with diabetes, maybe from teenage even to adulthood? Can they really, what can you say, without the necessary or the training that is required to be an endocrinologist, for example? What can you say about this?
It's a great question, Tino, and the answer is I don't think there's a one-size-fits-all answer. I think it depends where you're at. I think it depends on the resources that are available. So when you look, certainly places like Africa, where we know there are not as many endocrinologists as there are, even in the city of Philadelphia, even at my single institution in the city of Philadelphia. So what becomes a challenge in the US is we have over 30 endocrinologists in my division, plus our diabetes educators, plus our dietitians, plus our psychologists and our social workers. And because of that, we become very, very specialized. So I'm an endocrinologist, but almost all I do is diabetes right now. And then I look at the complete opposite side of that coin, where if you are the only doctor, the only nurse, the only medical professional in an area, you have to see it all, right? You are the only option that these people have. And so I think we have to think realistically, how much can you expect of one person? And there's certainly benefits to the formal training. I think being connected with other people, seeing more complicated cases, learning how to recognize things, that's so important from a medical education standpoint, because you can't know it all, you can't do it all, you can't train your brain to think about everything possible. But I think with the right support, with the right mentoring, I do think that people who are not endocrinologists can get to a place where they're prepared to support people with diabetes through various aspects of their life. And there's some really interesting models that have done this. There's a program in the US where it is trying to use telemedicine to give people in lesser resource settings access to a specialist. So they're providing the care in the places that they live, but knowing that they have the support of an expert to help them. So I think we need to start thinking outside the box. What can we do with the resources we have to prepare these medical teams to take care of the people in their communities who need them?
Wow, that is bravo. Supporting people where they're at. So I think it resonates with mostly like the content that you probably see on this podcast. Like this is what everybody that we're bringing onto this podcast is talking about. I think that should be the talk of the moment. It should serve as an inspiration to all the junior doctors, whoever is watching this podcast, because this is what we need now to bridge the gap. We need to work together. We need to go to where these people are, what resources that we have, and how best can we use them so that people can benefit, so that we can contribute and improve the quality of life for people living with diabetes with the resources that are available to them. It depends in the context, like she said, to say it depends mostly with the context where you are. Because we cannot really say if you only, all you have is a general practitioner, maybe say in the less remote areas, then we cannot say a general practitioner cannot treat a person living with diabetes when they are the only ones that are there. So, but it's also good to have these kind of training so that you know you'd serve as an expert in the things that you do. So Dr. Brynn, we cannot thank enough your involvement, your contributions, you just as a medical doctor, you also sharing from your lived experience with diabetes. You're also focusing more on the research. And there are a number of things, especially the things relating with your history, with your background. They are the things that are driving you to lead some of the things that you're doing. So like my interest really is to ask you to say, okay, what sparked your interest to further your research, or maybe to focus on transplant diabetes and the cystic fibrosis-related diabetes?
Good question, Tino, and there's a bit of a crazy story I have to give you as a background for that. So I actually had a heart transplant myself about 10.5 years ago now. Grew up with diabetes from 5, and then that on top of it. What happens with transplants, some of the medications you have to take so that your body doesn't reject that organ can actually cause diabetes. So as a person who had experience with both of those things, I was sort of fascinated by it. It's a real challenge. Those are two very complex medical conditions for people to have to handle, especially if they're not medical professionals. So I was interested in learning more about that to better support that population. And in pediatrics, fortunately, we don't see a ton of post-transplant diabetes. We don't see as many transplants. Kids tend to have better islet cell function, so they're not as likely to get diabetes. And I actually found a mentor who is still a close friend and valued mentor to this day, who was doing work on cystic fibrosis-related diabetes. So that population's a little bit different because there are inherent defects in the pancreas, the same defects that impact the liver. They impact the pancreas and insulin secretion and insulin sensitivity. So up to 30 to 40% of adults with cystic fibrosis will develop diabetes too. And although I don't have cystic fibrosis, there's that level of medical complexity. So what I liked about it, I think intellectually, the post-transplant and the cystic fibrosis, they push me a little bit. But then again, I also have this emotional connection to it. So what I've done there, I'm doing a study right now looking at cystic fibrosis and thinking about how we can do a better job screening for it. So for diabetes, when you hit 10, once a year you have to have an oral glucose tolerance test. These families go through lots, hospital admissions, lots of challenging medications, and when you ask them how they feel about the oral glucose tolerance test, the answer is terrible. They can't stand it. You have to come in fasting. Nobody likes the glucola. And there's a lot of work happening right now to see if we can actually use CGMs to diagnose it. But until we get there, the project I'm doing is looking to see, could we actually do this testing in the house, right? Because we were talking before, some people have a long distance to come to clinic. You know, imagine a 3-hour trip to clinic, you have to come in fasted, it has to be first thing in the morning. So I'm looking at the accuracy of different ways to measure blood sugars to see if we can find a tool that might actually let people do this in their homes and make it a little bit more convenient until we have even better, less invasive approaches.
Wow. I don't know what to say. Thank you so much for sharing your experience. Like with everything that she's doing, she has got a background with it. If it's something that you face, something that you had as an experience, something that you experienced, then it pushes you to trying to correct those said narratives that were in existence. Because if she hadn't like cared enough, taken a leap of faith to do the things that she's doing, probably there was no one who was going to do it the way she does it, because she was a victim once, but now with the background as a medical doctor, it actually helps. So that it should serve as an inspiration to those of you that are watching that finds this interesting. So thank you so much, Dr. Brynn, for sharing about these things that you're doing, and we're looking forward to learning more, reading more for your researches. And when they get published, I don't know if people have to pay to be able to access those researches, especially they are published by these journals that publish them, but we're looking forward to learning more from your work and probably what you're doing in this space. We can open for that.
Thanks so much for having me, Tina. Really great conversation. If I can just add one parting word, if I may. It's taken me a long place to get to this point where I can openly talk about this, where I can be comfortable sharing all of this. And what I learned over time is things happen to you, right? Like, you got diabetes, I got diabetes, I need a heart transplant, and in the moment I wasn't happy about it. I was very not happy about it, to put it nicely, and I struggled for a long time. And what I finally learned is you can't control what happens to you, but you can control how you react to it. And if you own that, and if you choose to focus on that piece, what you can do, that's how you can thrive and succeed despite all these challenges.
Wow, you've heard it all. Thank you so much, Dr. Brynn, about this. So we need really to keep on doing what you're doing, researching, learning, even if you're a medical professional. Continue learning, continue doing the research. We need you to do the research so that your work will be balanced. You know the things that you're doing, not just administering insulin, but you know why you need to do what you're doing. So thank you so much for that, for serving as an inspiration and a beacon of hope to so many others that will be listening to us. So this is the final segment of our podcast, and just amazing podcast that we had with Dr. Brynn. Lots of inspiration, lots of encouragement for you to learn, to see how best you want to improve yourself working in diabetes or whatever field that you're working in. So we wanted to ask Dr. Brynn, and I know maybe her as a director, technology rather, at the Diabetes Center. So I wanted to know from her, like, if she could choose like one device to help improve the outcomes for diabetes, for people living with diabetes, either a pump or a CGM, what would you choose and why? If you could just choose one. I know they are all important, but I mean...
They are. It's a good question, Tina, you're right, because resources are limited and sometimes you have to pick and choose. I think what we've seen time and time again is the CGM is if you have one technology, that's the one, right? Because you need that awareness of your blood sugar to be able to do anything. The pumps alone, before CGMs existed, they didn't lead to huge improvements in A1C, whereas we saw much more when CGM was introduced. Obviously, seeing your blood sugar numbers also takes a certain amount of motivation. If you don't have a pump where it sees that you're going up, it automatically gives you more insulin. You have to be motivated to give that injection or to exercise or do what it is that you need to do. But I think without the awareness of where your blood sugars are, I don't think the pump is quite as helpful.
Thank you so much. And maybe the last question that I would ask, I mean, you heard from her, but they're all important, right? They're all important. But maybe our last question to Dr. Brynn would be like, tomorrow, we know that she's going to be speaking at the Advanced Technology and Treatment for Diabetes. So we just wanted to share with us like the highlights, not everything. If you want to know everything that she will be saying, you need to attend the ATTD conference. So I know that she's going to be speaking on Saturday, rather. So if you could just maybe share with us the highlights and maybe just words of closing, words of encouragement to people listening, watching, whenever they will listen to this. Over to you.
Give a little teaser, huh? Increase the audience. I can do that, Tina. So I was telling you before about my work using apps for diabetes education. In the session that I'm presenting in, it's actually focused on women in diabetes. So the way I'm going to connect that to education is that in pediatrics, so much of it is the women who do the teaching. So we know that 70% of pediatric endocrinologists are women. In the US, upwards of 90% of diabetes educators are women. And we know that oftentimes it's the mother who's doing the primary diabetes caregiving at home. Not to say that the fathers don't support and do things in other ways, but who's making sure the blood sugar gets checked, that the carbs get counted, and the insulin given? It's usually women. So I am going to talk about the role of these particular women when it comes to thinking about using apps to teach people about diabetes technology. And I've actually done research in all of those groups. So stay tuned for Saturday, and I'll tell you a bit more about all of that.
Thank you so much. Thank you so much. That is just incredible. Yeah, it's always good to be at a conference. I mean, what brought us to this is the conference that we have tomorrow, that is starting tomorrow. But of course, we found time to do the podcast. So I cannot thank you enough, Dr. Brynn. And a big shout out to Belinda, who is holding the camera. behind. Oh, like, thank you so much for that one. So that's just that means a lot to the world that is going to be watching this podcast, not just to me, because you're doing it for the entire world. It's a global podcast, right? So I don't know, do you have any last words to the audience?
Any last words? I cheated. I think I gave them earlier.
I know that.
Can we use those? I don't think I can do any better than that.
Okay, great. So